So initial home treatment, what can you do? You can assess the severity of the patient. Symptoms and signs suggestive of a more serious exacerbation, such as marked breathlessness. Patient is not able to say any words. So these are the signs and symptoms of marked breathlessness. Use of accessory muscles. There is intercostal in drawing. The patient is getting dull, drowsy. That means the patient is even developing CO2 narcosis. So look out, initial treatment, you can give a short acting bronchodilator, two treatments 20 minutes apart, 2 to 6 puffs, 2 to 6 puffs with either a MDI or a nebulizer treatment. So good response, no wheezing or dyspnea. Peak expiratory flow greater than equal to 80% of the predicted. Incomplete is a PEF between 50 to 79 and a poor response is PEF less than 50%. Peak expiratory flow is generally either can be calculated on the spirometry or there is a portable peak flow meter. So it is a portable handheld device in which you tell the patient to blow. And there are gradings, and based on the gradings, you calculate whether how much obstruction is there in the patient. So if it is a poor response, if the distress is severe, call the doctor, call the 911 or maybe 104 in case of a ambulance in Indian scenario. So when talking about the treatment in emergency department or urgent care settings, a proper, very much important is go through a proper history, go through a physical examination. We have seen in the hospital, as soon as the patient comes to the emergency, there is one staff who will be there putting the patient on bed, making the mask, attaching to the patient and giving as much as oxygen is there, maybe 10 liter, 14 liters, 15 liters, how much oxygen is there. Even without dwelling on the history, even without doing a proper physical examination. So you have to understand what are the onset and causes. Whether it is a condition of asthma or COPD. Why? Because oxygen is a drug, and if you give more oxygen in a patient of COPD who has already retained CO2, that will lead to cutoff of the ventilatory drive, that will lead to more CO2 accumulation, and the patient will die within minutes. So if you see a patient, many of the patients who have been put on 10 to 15 liters of oxygen of patient of COPD, he will get more drowsy within in a couple of minutes or so, and then ultimately you have to put the patient maybe on ventilator or the patient collapses within minutes or seconds. So asthma related risk factors for death include what? History of near fatal asthma. What is a near fatal asthma? Asthma requiring an intubation or a mechanical ventilation. So if the patient of asthma generally doesn't retain CO2, but if he or she starts retaining CO2, then that is a near fatal asthma. Hospitalization in the past year, recent use of oral corticosteroids, no use of inhalational corticosteroids, overuse of SABA. So if you see a patient of asthma, many of the times we see that overuse of SABA, as soon as he gets shortness of breath, a straight pump of SABA is being taken. History of psychiatric disease, poor medication adherence, lack of a written asthma plan, or a food allergy. So as soon as the patient is there in your hospital setup or clinic, or if the patient is getting discharged from the hospital, there is a written asthma action plan which has to be handed over to the patient. What has to be done at the home, how to take medications, which things to avoid, which things to follow. So there is a proper beautiful list of it.